So it's really been an interesting morning so far, and I'm so happy to be included. I'm going to try to talk about breast cancer genetics, what you really need to know, what the essentials are. I'm sure I won't get everything in here since it's a short talk, so feel free to ask questions in the chat. So chromosomes, genes, DNA make up the genes, and genes are organized into chromosomes. But what we care about when we look at genes is how do the genes provide instructions for telling the cells what to do? And they do that because they code for proteins. So when we are looking at the letters of the gene, the DNA letters in the gene, we want to make sure that that pattern that you see here, where all the pinks match with oranges and all the purples match with greens, that's actually the way that code is. There are only 4 letters in the code, and it's really amazing that they have to be in exactly the right order and matched up together for the protein to be completely normal. But because they're DNA letters, you can read them as a code, and that way you can detect typos, or you can detect bigger errors, like when you're missing a whole piece of a gene, or a whole piece or a whole gene completely, even pieces of chromosomes. Most of us have subtle changes. We have lots of substitution letters, like typos, most of which probably don't really affect anything, but they do contribute in some small way to the things that make us individuals. In cancer genes, we want to make sure that these genes that predispose to cancer are spelled correctly, and we look for errors or typos. And since we know they're not all the same, we'll talk about that a little more. So the idea of susceptibility genes, these are not cancer genes in that even if we're born with a typo in one of these genes, it doesn't mean we're born with cancer. We're born with an increased risk of cancer. And how does that work? Well, we have 2 chromosomes in pairs most of the time, 26 pairs of chromosomes. And because I assume most of the people on this call are women, we really do have 26 pairs because we have 2 X chromosomes, whereas men have 25 pairs and an X and a Y. It's not their fault that Y chromosome is smaller, it doesn't have much information on it. Maybe explain some of the issues that make us different. But we have 26 pairs, and at every site, we have then 2 copies of a gene. And in normal cells, I mean, all of our cells, it's possible for something to come along and affect one of those copies. Here's an example where the whole end of the chromosome is knocked off. So of course, the gene that matches the red one is missing. But here, so we started out with 2 greens. Something made a change, so we had a red and a green. That red one's not working. Something knocked off the second gene. Now that gene's completely missing, and it's possible for that cell then to go on to become a tumor cell. The idea is that in people who have an inherited risk, 1 copy isn't working from the beginning in all of the cells. So it's much easier for only 1 second event to happen than for 2 events to happen in a cell. So obviously 2 events happens all the time because cancer is a very common disease, not just breast cancer, lung cancer, colon cancer, skin cancer, all the time. So it's easy enough for these things to happen even in the same cell, which is necessary for tumor to develop. But it's that much easier if you start out with 1 copy not working, so you only need 1 extra event. And that's why for many inherited forms of cancers, we think cancers should occur in younger people because it takes fewer events, takes less time, that you can have more than 1 cancer because it's easier for these things to happen. So when we look at families, these are features we look for. So this is just the artist's rendition of this. These are mutations or errors being introduced into the gene, smoking, chemicals, the environment, radiation. And if you have otherwise normal cells, you may just have these things happening kind of all the time. Then if you start out with all your cells having 1 error, then the second one comes along, it's that much more often. People have talked about this as the brakes on a car. If you have the front and the rear brakes, then of course the car can stop. If you're missing the front brakes, the car's still going to stop with the rear brakes. But if something happens to the rear brakes, then you're in trouble. How much cancer is really due to these strong genes? Only about 10 or 15%. Most cancer occurs because of other things, lifestyle, just aging, I'm afraid, lots of opportunities for cells to divide and make mistakes. And then there's inherited risk. So what are the clues that your family or someone's family might have an inherited risk? Well, if there's more cancer than expected in the family. So we just said cancer is really common. The risk of cancer in the population is actually 1 in 3 or 1 in 2 if you count skin cancer, because there's a lot of skin cancer out there. Um, but how much breast cancer? Well, 10 or 12% in people if they live a long time. That's pretty common. But if you're looking at families and you see several people with cancer, multiple generations, so it looks like this might be inherited, parents, grandparents, the next generations, the younger ages, the diagnosis that I mentioned, some association with other kinds of cancers that might be linked by some of these genes, like breast and ovarian cancer, we know, pancreas cancer in some families, advanced prostate cancer. Prostate cancer is so common, it can't be all prostate cancer, but the more aggressive type, and male breast cancer, which we all know is rare. It's about 1% as common as generally as female breast cancer, but it's rare. So when you see it, you have to pay attention. Also, people who develop more than one cancer. So you've survived breast cancer and gone on to get another one or to get ovarian cancer. That might be a clue. And sometimes we said these cancers are linked together. So getting breast cancer and skin cancer, that's not such a signal because they're both quite common, breast cancer and something less common like ovary. And it's true that people of Jewish descent have an increased risk of the BRCA1 and 2 genes, but cancer genetics, cancer genes are seen in all groups, every race and ethnicity. And that's my dog, and I apologize, I can't do much about that. This is a pedigree, a family tree. And if you say, come and see a genetic counselor, they'll draw your family tree. Women are circles, men are squares, that's just convention. And on this family, you can see, here's a young woman with breast cancer at 32. We'd all be worried that there'd have to be some special reason for that to happen, although it's not always genetic, I promise. Still, not as often as you'd think. But in her family, on dad's side, there are breast cancers in all the generations at remarkably young ages, and this woman who has 2 different cancers. So even though it's through the father and not through the mother, we'd worry that this side of the family might have an inherited cancer risk. Now, the mom did have breast cancer, so maybe this pair of daughters was worried about getting breast cancer, but maybe they were waiting a while because mom was almost 50 when this happened, and grandmother and the other 2 aunts had not had cancer. Could there be something genetic here? It's possible, but it certainly doesn't hit you between the eyes the way the father's side does. So the message here is really that cancer can come from, the cancer risk genes can come from either parent, fathers as well as mothers, so they are not off the hook for this. Why do we do genetic testing? Well, primarily to identify people who have increased risk of cancer so we can follow them more closely or help them to think about ways to reduce their cancer risks, and we're learning more about how to do that. Also, to find people who don't have increased risk. If there's a gene in the family and someone did not inherit it, they don't have the same increased risk, even though they have the same family history. And they don't have to have extra MRIs and biopsies and all that goes with that, or consider surgeries to reduce their risk. And these days, we even add that there are some special treatments if people do get cancer that can be used only if they have an inherited basis for their cancer. They don't work in people who don't. So that's another reason, but that's not the one we're mostly focused here. How's genetic testing done? Well, of course, it can be done on a blood test because we said all the cells in the body have these altered genes. So it can be done on blood, but even easier now, these tests can be done on saliva. So for those people whose family members are chickens and don't want to get their blood drawn because they don't like getting stuck by a needle, although naturally no one likes being stuck by a needle, it is possible to have a completely accurate test done on saliva. There are plenty of white blood cells in your saliva. This is the size, is a kit that gets sent home from one of the testing labs. There are several, and this was in no way to advertise the lab or this Origin kit, which is used for research. But all they do is send a kit from the lab, and you provide a saliva sample into the kit and pack it up and send it back, and it's completely accurate. However, the fact that they can send you a kit and you can send back the saliva doesn't mean that you shouldn't have genetic counseling to think about what are you doing, what can you learn from this, and what can't you learn from this so that you can move forward. Now, this is just a quick primer on the results themselves. So in the center here is the alpha helix. You all recognize the arrow of the DNA that we've shown, and this is a normal sequence, also called wild type sequence. And for example here, we're just going to use the word theater. What happens if there's an error? Well, X and Q have nothing to do with E and A. and here's the mark on this chromosome, in this gene, I'm sorry, to show you that here, this would alter the sequence. It should alter the protein, and it might not make the in this example gene do its function very normally. This is called, these days, it's been renamed a pathogenic variant. They stopped using mutation because they thought it sounded pejorative, that people were being called mutants, and that's really totally unfair. We all have altered genes. So they now call it a less easy word, a pathogenic variant, but it means the same thing. So here's somebody who's got a pathogenic variant in this, and it changed the whole word. Doesn't make sense anymore. But what about the subtle changes? So here's a change at the same place, but it's slightly different. Instead of changing X to Q, so now we had theater spelled ER, now we have theater spelled RE. So still theater, we all recognize that it's theater. Is it going to function exactly the same way? Maybe, or could it be a very subtle difference? And so a lot of times when people have genetic testing, they get a result that's called a VUS, or a variant of uncertain significance, which means we're not totally sure whether this is just a minor typo or whether it's at exactly the wrong place in the gene, and therefore it does have some functional consequences. Usually we tell people that 95% of them are just typos, and eventually they'll be reclassified definitively as having no significance. So you have to check back in and find out if yours has been reclassified. If you're looking for a family, if you look for a mutation, families usually only have one mutation. That's not always true, but it's usually true. So you remember the old Where's Waldo? And it's true that in a family, once you find Waldo, once you know where the mutation is, you really could test everybody else in the family just for that particular spot. We used to do a lot of this. It was cheaper. It was definitive. Now testing is not very expensive. So we usually test whole genes on everybody anyway, but the concept's still the same. If there's a mutation in the family and someone shares it, that's not surprising if they've inherited it. But if they don't share it, that is a definitive negative result, and it's informative. We don't always have the option. Sometimes family members haven't been available to be tested, or they don't want to be tested. They don't want to think they could have passed something on. But if it's there, it can be very helpful. How much cancer risk with these genes? Well, so here's the population risk, high enough for breast cancer, but with BRCA1 and 2 in particular, the risks are much higher. The risks of second cancers are higher. The risks of ovarian cancers are also still significant, although BRCA1 is higher than BRCA2. Now we talk about other cancers like melanoma and pancreas and male breast cancer, the ones I mentioned before, but you can see that the magnitude of risk is nothing like the breast and ovarian cancer risk. Enough to make us think about it, and sometimes enough for screening, but often just enough to know. Oops. This is just for people who like graphs. Here's BRCA1 and 2 at the top of a list of breast cancer susceptibility genes. So here's ATM. So I know somebody's interested in that. And check 2. Here's BRCA1 and 2. They're way up here at the 50 or 60% risk. Here's ATM in yellow, check 2 in orange, and here's the general population risk at 12%. So these are higher, but they're more like atypical hyperplasia. They're not nearly as many times higher, as much increased as the population risk. So we often don't think that the management should be as aggressive. PALB2 is a gene that's gotten more attention in the New York Times lately. It's more like BRCA1 and 2, and that makes sense because PALB2 was always the pal of BRCA2. It was discovered here at Dana-Farber by David Livingston, and they named it. And then RAD51CND somebody had asked about, and those are genes that in breast cancer are here. They're more ovarian cancer genes. What do we do about them? Well, there are lots of guidelines for management of these things, and we discuss these in the clinic, of course. They look a lot like every other high-risk thing where we do mammograms and MRIs and exams. We just start early. We start often at 25 with the MRIs and add radiation-based mammograms later on. There's a lot of controversy about ovarian surveillance. Most of it doesn't work. We're not big fans here. We do have programs for pancreas screening because everybody's worried about that, but that deserves special discussion. Even in the presence of a mutation, you have to also have a family history before you'd want to do that. And then prostate cancer starting younger at 40. And then there are surgical options for reducing risk, and these are very individual. So we talk about those. Just to remember that we talked a lot about the higher risk genes. For these more moderate genes like ATM or CHEK2, we start screening, but we start at 40 instead of at 25, although it's affected by family history. So if you have an alteration in one of these genes and a family history of breast cancer at younger ages, we might be modifying some of these effects. So all these things are discussions, and it's hard to just look them up in a table and say, oh yeah, that's me. Somebody had asked about reproductive issues, and it is true, amazing as it is these days, that you can select against these altered genes. So if you find that you have a BRCA1 or BRCA2 mutation and you don't want to pass that to the next generation, it is possible to avoid doing that. There's also another complicated decision, but it's especially something to know is an option for often your children or for yourselves, for siblings. It's even a reason that men might want to know that they have such a gene so they don't pass it on, since, as we said, it can be passed by women or men. So this is something that the fertility people can help with. The big problem with it is that, of course, that insurance doesn't pay for all of it, although they do pay for part, and it is not part of the usual testing of embryos and fetuses now to look for Down syndrome and other things. Just to remind you, the reason that we're interested often in helping families define whether or not they are at high risk is because we want to try to help them avoid the risk, the cancer risk. And this is just a complicated slide, but just because there are a lot of different things to think about when you're thinking about prevention and what kind of factors might contribute. And we've heard about some of them here this morning already. Things you can control, like diet and exercise and alcohol intake, things that you can't, like your genes. This is just to say that there is going to be a prevention trial for women with BRCA1 mutations who've not had breast cancer. This is a big international study that's being run from Austria and Australia so far, and the US, which I'm actually leading, is going to start this fall. We're just waiting for more paperwork, but this is the drug denosumab or Prolia. It's a drug for osteoporosis, for bone loss. But in biology laboratories, it's been shown to be important in how breast cancer develops in BRCA1. And so there's a trial now to see whether we can develop something that's not surgery as a way of helping to reduce cancer risk. And here you are trying to decide what to do. And all of us in the clinic have familiarity with the issues in genetics enough to help you decide, do you want to go talk to a genetic counselor or one of the genetics experts over at Dana-Farber, and to help make that possible for you. So thanks, Terry. I think that's it.
Thank you very much, Dr. Garber. That was wonderful. I'm going to just ask you one question before we move along, and thank you for answering the questions that were sent in advance. One question that came in right when you started, a very eager participant wants to know your thoughts about incorporating polygenic risk scores for risk assessment.
Wow, what a crowd. Polygenic risk scores are really interesting. They're looking at many different sequences in the DNA, small changes that all of us have that are not, each one is inherited individually, but mostly when you think about them, you have to group them all together for them to have any power. Otherwise, they're such tiny effects, any one is not helpful. And people have known about this and been studying these for many years now. And only recently have we been able to say that if you look at hundreds of these together, you might be able to use them to quantify risk better. So one way is to say, can we help, instead of just giving you these big statistics, lifetime risks of 80% or 60%, can we individualize risk for each woman? And we hope that these personalized risk scores will help us to do that. And what about for people who don't have genes like BRCA1 and 2? It's expected that these personalized risk scores will help us estimate the family component of risk better than we do now, where we just say, I don't know, does your mother have breast cancer like mine did? Does that increase your risk? This might help us quantify that risk as well. But I would say that even though there's been a lot more work in the last several years and some very interesting analyses, I consider this stuff still preliminary. And one of the testing labs gives this information, and it would be okay, except that when they get to the edges of risk, like really high risk, some people I've seen who've had a score in the lifetime risk of 60%. This is based on very tiny numbers of people. It is not really ready for prime time. So I would discount that part of the test report myself for now. But I do think that over the next several years, this is going to become part of what we do based on a lot more information.